welcome to the deep dive. Today we're zeroing in on Polyarteritis Nodosa pan.
That's right.
Think of this as your rapid-fire need-to-know guide to this systemic vasculitis. It's really built to help you nail down the key facts for revision.
Exactly.
We've got a comprehensive set of notes here, and our mission is, well, pretty laser-focused. Extract the essential information about PAN.
Precisely. We'll be dissecting these notes to give you a sharp understanding of PAN, what defines it, what might trigger it, how it affects the body, and, crucially, the diagnosis and management aspects.
Okay, consider it our streamlined strategy then. Let's dive straight into the definition. In simple terms, what is Polyarteritis Nodosa all about?
Okay. So, at its heart, PAN is a systemic vasculitis. That means inflammation of blood vessels, throughout the body.
Systemic. Right.
And its primary target is medium-sized arteries. This inflammation leads to damage in their walls, particularly the muscular layer. You can sort of imagine the artery wall getting thickened and, well, weakened by this inflammation.
Medium-sized arteries.
Yeah.
Like the ones feeding which organs?
Yeah.
Kidneys, gut.
Exactly. Think kidneys, gut, nerves. When these medium vessels get inflamed, it can have really widespread effects. Now, the 2012 Chapel Hill criteria are pretty vital here for a precise definition.
Okay.
They classify PAN as a necrotizing arteritis. That's inflammation so intense it actually causes cell death in the artery wall, affecting medium or small arteries. But, and this is a key distinction,
Yes.
it does not involve glomerulonephritis. That affects the kidney's filtering units. And it doesn't involve vasculitis in the really small vessels like arterioles, capillaries, venules. Also, it's not associated with those ANCA antibodies.
Ah, ANCAs.
Right. If ANCAs are positive, you're probably looking at a different type of vasculitis altogether.
So no kidney filter involvement, no ANCAs. Those are big clues. It might not be PAN.
Absolutely. Major red flags for other conditions. And another really important feature of PAN is where it doesn't occur. It can affect almost any organ system.
Almost. So where are the exceptions we really need to remember?
The vital exceptions are the pulmonary arteries in the lungs and the glomerular arteries in the kidneys.
Okay.
Keep this phrase locked in. PAN doesn't play in lungs or glomeruli.
Dan doesn't play on lungs or glomeruli. I like that. That's a brilliant memory aid. Now, the notes also mention cutaneous PAN, C-PAN. Is that just a skin version?
Not exactly. C-PAN is generally milder, primarily affecting the skin. You might see things like subcutaneous nodules, bumps under the skin.
Right.
That net-like purplish rash, levetta reticularis, ulcers, maybe some localized tissue damage. Interestingly, C-PAN is often linked to strep infections.
Streptococcal infections.
Yes. And the good news, generally, is that it usually stays in the skin. It very rarely progresses to that classical systemic PAN.
Okay, good distinction. So what actually triggers this inflammation? What's the etiology?
Well, this is where it gets a bit hazy. The exact cause, still unknown. But the notes suggest infections might be triggers for some people. What we do know is it involves an abnormal immune response. The body's defense system seems to mistakenly attack the artery walls. Autoimmune mechanisms are likely involved.
So our own immune system gets confused, starts attacking healthy blood vessels.
That's the current thinking, yes. Probably a complex mix of potential triggers, like infections maybe, and the individual's own immune system reaction.
And who's most likely to get PAN? Any specific risk factors?
Our notes point towards adults, typically between 40 and 60 years old. That's the most common age group.
40 to 60.
Yeah. And interestingly, despite a lot of research, there aren't really clear genetic or environmental links that stand out consistently. So for someone in that age range with suggestive symptoms, PAN needs to be considered.
So it can just sort of appear without obvious predispositions.
It seems that way, often. Okay, let's get into the nuts and bolts of what's happening pathologically, the pathophysiology.
Right, break down how PAN develops and causes problems.
So the central process, as we said, is inflammation and damage to the walls of those medium-sized arteries. Now, this inflammation can lead to nodules, little bumps along the arteries, or even aneurysms.
Aneurysms.
Like ballooning. Exactly, balloon-like bulges, weak spots caused by the damaged vessel wall.
And why are those dangerous, the nodules and aneurysms?
They directly mess with blood flow. The inflammation, the narrowing, the bulging, it all impairs blood supply. That causes ischemia.
Lack of oxygen.
Right, lack of oxygen and nutrients to the tissues and organs those arteries supply. Over time, this can lead to significant, potentially irreversible organ damage. Plus, the inflammation itself can directly affect the tissues around the vessels.
Makes sense. So if a patient comes in with symptoms that could be PAN, what else needs to be on the differential diagnosis list?
Ah, yes, the differentials. This is critical. You need to consider other conditions that can mimic PAN. Our notes list several. Other large vessel vasculitides like giant cell arteritis, Takayasu arteritis, though they usually hit larger arteries. Then there's microscopic polyangiitis. Crucial difference there. It is often ANCA-associated and affects smaller vessels.
And what about connective tissue diseases, like lupus?
Yes, absolutely. SLE, rheumatoid arthritis, eosinophilic granulomatosis with polyangiitis, EGPA, or Churg-Strauss. They can sometimes overlap in how they present.
Okay.
Then you've got other vasculitides, Hanot-Schindler-Purpura, granulomatosis with polyangiitis or GPA, Churg-Strauss, again showing the overlap, and even Kawasaki disease, though that's mainly kids.
Wow, that's a broad list. So how do you distinguish PAN? What are the keys?
The key is really careful assessment. Look at the size of the vessels involved. Is it mainly medium? Check for those key features. Glomerulonephritis, ANCAs, are they absent? Then put together the whole clinical picture and the lab findings. It's rarely one single thing. It's the pattern.
Right, the overall pattern. Okay, let's zoom out a bit to the bigger picture. How common is PAN? What's the epidemiology?
Well, in the UK, it's rare. Prevalence is around 3.1 cases per 100,000 people, according to these notes.
Pretty rare then.
Very. It affects all ethnic groups, but interestingly, it's more common where hepatitis B infection is more prevalent. That association is important.
Hep B.
Got it.
And the notes mention different types.
Yes. There's primary or idiopathic PAN, that's the most common cause unknown. And then secondary PAN, which is linked to underlying infections, Hep B, Hep C, HIV.
Okay.
And there's also a genetic condition, DDA2 deficiency, that can look a lot like PAN clinically. So that's another one to keep in mind sometimes.
DDA2. And the typical age?
Onset is usually around 50. It's pretty uncommon in childhood. And we see it diagnosed more often in males than females.
More in men.
Yes. And an interesting trend, the incidence seems to be decreasing, likely due to stricter diagnostic criteria and, probably significantly, the success of hepatitis B vaccination programs.
That makes sense. Good news. Now let's get into how PAN actually looks in patients. What are the common clinical features? What should make you suspect it?
The presentation can be really diverse and sometimes quite vague early on, which is a challenge. Common general symptoms. Things like persistent fever, unexplained fatigue, weight loss, aching muscles and joints. Very nonspecific stuff sometimes.
Okay, but what about more specific signs?
Signs that should raise suspicion include a new skin rash, abdominal pain, sometimes severe, and neuropathy, nerve damage.
Are there any particular signs that really point towards PAN?
Yes, several. Developing high blood pressure, hypertension, especially if it's new or hard to control. Testicular pain in males is a classic, though not always present. Levato reticularis, that net-like purplish skin pattern.
Right, I've seen pictures of that.
And blood in the urine, hematuria, along with signs of kidney function decline. Now here's a subtle point. Paranuclear ANCA, PANCA, while PAN is typically ANCA negative,
Yes.
it can actually be positive in about 20% of classic PAN cases. So negative ANCA is suggestive, but a positive PANCA doesn't absolutely rule it out in that small fraction.
Okay, that's a really important nuance for exams. 20% can be PANCA positive. And the Hep B link again.
Yes, around 30% of PAN patients will have evidence of current or past Hep B infection. It's a strong link.
So what are the very first symptoms someone might notice?
Often quite vague, as I said. Low-grade fever that hangs around, losing weight without trying, headaches, general muscle aches, myalgia. But a key feature to watch for is peripheral nerve involvement.
Nerve problems.
Yes, specifically mononeuritis multiplex. That's where multiple individual nerves in different parts of the body are affected. It's the most common neurological sign. Skin involvement is also very common purpura, that lovedoid rash, subcutaneous nodules, painful necrotic ulcers even.
And does it matter which organs are involved in terms of how serious it is?
Absolutely. Involvement of the GI tract, the kidneys, the heart, the central nervous system, that generally means higher mortality risk.
For example.
Well, kidney involvement can lead to hypertension or even acute kidney injury. GI symptoms, like really bad abdominal pain after eating mesenteric ischemia, can progress to bowel necrosis or perforation. serious stuff. And in childhood pan, muscle pain, myalgia is super common, like 72% of cases.
So diagnosis sounds like piecing together a puzzle from lots of different clues.
Exactly right. Accurate diagnosis needs careful integration of the clinical findings, plus results from biopsies and specialized blood vessel imaging angiography.
Are there official criteria?
Yes. The American College of Rheumatology, ACR, has adult diagnostic criteria. You need 3 or more from a list, including unexplained weight loss over 4 kilograms, levator reticularis, testicular pain, myalgias or weakness, nerve involvement, mono or polyneuropathy, high diastolic BP over 90, kidney issues, raised BU and creatinine, Hep B infection evidence, arteriogram abnormalities showing aneurysms or occlusions, and a biopsy showing specific white blood cells, polymorphonuclear leukocytes in artery walls.
That's a lot to remember. Any chance of another mnemonic for those ACR criteria?
Let's try one. How about weight high five? For weight loss, evidence of Hep B infiltrate on biopsy, granulocytes, the cells, high BP, testicular pain.
Wait. Okay.
Then high five, hepatitis B again, inflammation, systemic, vasculitis on arteriogram, extremities, neuropathy, fever, maybe add involvement of kidneys, visual skin signs, liver extremity nerve issues again. It's a bit clunky perhaps, but hits some key ones.
Weight high five. Yeah, I might just stick. Are the criteria different for kids?
Yes, slightly. For childhood pan, it's systemic inflammation plus either biopsy proof of necrotizing vasculitis or angiographic abnormalities in medium-small arteries, and at least one of skin involvement, myalgia tenderness, hypertension, peripheral neuropathy, or kidney involvement.
Okay, so we suspect pan based on clinical signs and criteria. What investigations confirm it?
It's definitely a multimodal approach. Clinical assessment, lab tests, imaging, you need them all. Blood tests are key for inflammatory markers, ESR, CRP, and serology for Hep B, C, HIV, given the associations.
Those ANCAs again, what's their role here?
We keep coming back to them. As we said, typically negative in classic pan. A positive ANCA strongly suggests something else, MSA, GPA, eGPA, so it's more useful for ruling pan out or pointing elsewhere.
Right, and biopsy and imaging, how crucial are they?
Biopsy is crucial for a definitive diagnosis. You need to see that necrotizing inflammation in small to medium arteries. Good places to biopsy are skin, superficial nerves like the sural nerve in the leg, or muscle.
Where do you avoid biopsying?
Generally, avoid kidneys or liver if possible. Higher risk of bleeding complications. Imaging, especially angiography, catheter-based or CTMR versions, is vital too. It can show those characteristic microaneurysms, especially in kidney and abdominal arteries.
Microaneurysms?
Yes. And newer techniques like FDG PTCT are emerging as non-invasive ways to spot vascular inflammation.
Okay, so investigations confirm pan. What's the management plan?
Right. Treatment goals,
Yeah.
suppress the inflammation aggressively, prevent organ damage, and manage symptoms. The cornerstone is immunosuppressive therapy.
Weakening the immune system.
Essentially, yes. Dampening down that overactive response. Corticosteroids, like prednisolone, are a mainstay, often used with other, sometimes stronger immunosuppressants.
Now, the notes say treatments are often based on expert consensus, not huge recent trials. Why is that?
That's a fair point. Pan is rare enough that doing large-scale randomized trials is difficult. So much of the approach comes from accumulated clinical experience and expert opinion from rheumatologists and others who treat it.
Makes sense. So what are the general recommendations, say, from ACR or the Vasculitis Foundation?
Okay, for active severe pan, the usual approach is high-dose glucocorticoids, maybe IV initially, then oral combined with cyclophosphamide, which is a potent immunosuppressant.
And for less severe cases?
For active but non-severe pan, still glucocorticoids, but maybe combined with something like azathioprine or methotrexate, which have slightly different side effect profiles. Once remission is achieved,
Yes.
you typically continue a non-glucocorticoid immunosuppressant like azathioprine or methotrexate for about 18 months to maintain remission while slowly tapering the steroids off.
What about that data-2 subtype? Different treatment?
Yes, good point. For pan caused by data-2 deficiency, TNF inhibitors, a specific type of biologic drug, seem particularly effective. They can control the disease and even reduce stroke risk, which is a concern in data-2.
And specific situations, like pan with active Hep B.
Absolutely. If pan is active with ongoing Hep B, you need to treat both. That means antivirals for the hepatitis, often combined with plasma exchanges to remove immune complexes.
Plasma exchange, okay. And kids, or just skin involvement.
For childhood pan, often IV and aspirin initially, steroids or maybe infliximab if needed. For cutaneous pan, mild cases might just need NSAIDs or colchicine. More severe or resistant CPAN might need prednisolone and other immunosuppressants, similar to systemic disease, but often less intense.
So very tailored treatment. Looking long-term now, what's the prognosis?
It depends. Key factors are which organs are involved, how severe it is at diagnosis, and how well the patient responds to treatment. Early diagnosis and starting treatment promptly are absolutely crucial for better outcomes.
How much better?
The notes show a huge difference. Untreated PAN, historically, a grim 5-year survival, maybe 13%. With modern treatment, it's dramatically better, around 80%.
Wow, that's night and day. Really stresses the need for treatment. What about relapse? Does it come back often?
Fortunately, relapse after remission is relatively uncommon in PAN, less than 20% of patients. And as we mentioned, the decrease in Hep B-associated PAN due to vaccination helps the overall outlook too.
That's encouraging. Finally, what complications can arise from PAN?
Complications stem from the vessel inflammation and the resulting organ damage. Things like organ dysfunction or failure, aneurysm rupture, which can cause major bleeding, persistent neuropathy, GI bleeding, skin ulcers.
Any really serious ones?
Yes, the most serious include stroke, bowel infarction, where the bowel tissue dies from lack of blood, renal failure, heart failure, and encephalopathy, which affects brain function. And we have to remember the long-term immunosuppressive therapy itself carries risks.
Like how?
Increased risk of secondary cancers and opportunistic infections. It's a balance.
Definitely a complex condition needing careful management. So to quickly recap, PAN is a systemic vasculitis of medium arteries, varied presentation. Early diagnosis, clinical clues, biopsy, angiography, and prompt immunosuppression are vital for improving outcomes dramatically. Understanding the definition, causes, effects, and management is key.
Precisely. It's rare, yes, but serious. Requires high clinical awareness and a systematic approach.
Absolutely. If you want to explore other key topics for your MSRA prep, definitely check out PassanSRA.com and also FreemSRA.com for loads of great resources.
And perhaps a final thought to leave you with. Considering how rare PAN is and how differently it can present, how crucial is it really to keep a broad differential diagnosis in mind? And what specific red flag signs should truly make you stop and think, could this be a vasculitis? It really highlights the need for sharp clinical thinking.
Thanks for joining us for this in-depth exploration. Until our next deep dive.